Welcome to Midrun Pedia. My name is Benjamin, and today I'm going to talk about Hirschsprung's disease. So in this video, I'm going to talk about the epidemiology of this disease. We shall look at some of the associated syndromes, the clinical presentation, the classification, the embryology, and how and what goes wrong during that to give rise to the Hirschsprung's disease, as well as some of the differentials and the management. So when we talk about Hirschsprung's disease, this is the congenital absence of enteric ganglion cells. So then the digestive system has its own nervous system that kind of works separately from the central nervous system, or can work separately from this central nervous system. So we have the two plexuses. We have the submucosal plexus, or what we call the Meissner's plexus, and the myenteric plexus. And in Hirschsprung's disease, we have an abnormality where we don't have these two plexuses. So when you look at the incidence of the disease, it occurs 1 in 5,000 live births, though worldwide it's hard to estimate the worldwide prevalence because of the discrepancies in documentation and everything else. But it has been seen to be found more in the males, so it's still no predominancy with a ratio of 4:1. Though when we have a variation of Hirschsprung's disease known as the long segment disease, the ratio is 1:1. And then we have familial cases, 3 to 5%. We have autosomal dominant or recessive patterns depending on the genes involved. And then we have increased risk in siblings. For example, if one child is affected, there's approximately a 4% risk for the next male sibling, while we have a 1% risk for the next female sibling. And if 2 children are affected, the risk is going to rise up to 33%. So some of the conditions that are associated with children developing Hirschsprung's disease, we have Down syndrome, that is trisomy 21, congenital heart diseases, kids who are born with ASDs and VSDs, the MEN2A and RET mutations, we have Waardenburg syndrome, the VACTERL, and then Smith-Lemmy-Opt syndrome. So we're going to look at the classification. So the classification is, we have a short segment, which covers about 75% of this Hirschsprung's disease. And in most cases, the rectum and the sigmoid are going to be affected, and it's the classic form. Then we have the long segment, which here occurs in 15-20% of cases. And here we have extension of the lac of ganglions to the proximal, from the proximal to the sigmoid. So you find that even the proximal colon is affected. Then we have total colonic aganglionosis that occurs in 3 to 5%, and even sometimes the problem could extend even up to the small bowel. Then we have the ultra short segment where the internal sphincter region only is going to be affected, and this one is going to be difficult to diagnose, as we shall see. So what happens is that during embryology, or the normal process, we have the neurocrest cells, and the neurocrest cells are going to give rise to the ganglia of the nervous system. So they're going to migrate caudally, or they're going to migrate from up, going along the GI tract between the 5th to 12 weeks, and they're going to be populating the Albach's plexus, that is the muscular layer, as well as the Meissner's plexus, it is in the submucosal. But what happens is that if we have failure of migration of these neurocrest cells, or the failure to proliferate, or the failure of survive, or maybe we have increased apoptosis within these cells, we're going to have a distal segment that is aganglionic. So if the cells migrate and reach a point and they stop, or they die, or they fail to survive, that place is going to lack the ganglions. So what is going to happen is that we're going to have an aganglionic bowel, and most of the time the ganglia, or these plexuses, are going to facilitate the relaxation of the bowel. They're the ones that cause the relaxation. Without them, without their inhibitory effect, we're going to have a sustained contraction. So we're going to have a spastic, contracted, and non-relaxing bowel. Because we know peristalsis is coordinated from proximal to the distal, the obstruction is going to occur because we don't have progression of peristalsis where we lack that plexuses. We don't have that rhythmic contraction and relaxation. So we shall end up with a functional obstruction. And then what is going to happen is that the proximal bowel the one that is up is going to become dilated, and we have what we call a megacolon because it cannot fit through that. Because the lumen in front is spastically contracted, then it is going to hypertrophy because it's experiencing a lot of force, and then we can have the chronic inflammation that is going to come in because as things get static, there is proliferation of organisms, and this is going to come with a lot of inflammation. Sometimes we have some genetics or genes that have been found, like the red proto-oncogene, and we have seen this one in men, the men syndromes, and it is the messenger gene that is most of the time affected when it comes to Hirschsprung's disease. But we have others like the EDNRB, EDN3, EDNF, SOX10, NRTN, and the FOX2B. And when it comes to the long segment and total colonic disease, most of the time these genetic abnormalities are strongly indicated. So when it comes to the clinical presentations, most of the time, 90% of cases are going to be in the neonatal period, and we shall have what we call the delayed passage of meconium, because when a child is born within the first 24 to 48 hours, we expect them to pass their first feces, and this is what we call the meconium. So when we don't have this, it's going to be a signal. Then we shall have progressive abdominal distension. As this child feeds, they're going to start having a distension, and then they will eventually start having a bilious vomiting. And the reason they're having a bilious vomiting is because we are vomiting up. As we fill up downwards, we are going to start vomiting up food that is mixed with the bile. And then they will have a refusal to feed because of this distension and filling. And then they have an explosive discharge of stools when you do an rectal exam, which is called the Scott sign, because remember this spastic segment is contracted downwards, and during the rectal exam you may accompanies opening up, and then you remove because of the pressure up, it's going to force things out very fast. Then sometimes enterocolitis may be the first presentation, and it's going to come in toxic because of the overgrowth of the organisms within the gut, and this is going to maybe the first presentation is the most common cause of death in kids with Hirschsprung's disease. Then abdominal distension and vomiting, other things we shall see. Then sometimes we can continue to infants or children where we shall have a history of chronic constipation from birth, poor weight gain, as well as failure to pray, and then they have pencil thin stools because of that narrowing. It's going to shape their fecal matter pencil thin, and then we have recurrent fecal impaction. Then we have the Hirschsprung's associated enterocolitis, and this is a very dangerous presentation, which occurs in 30 to 50% of children with Hirschsprung's disease, and it can occur before or even after the surgeries. So the clinical features of this Hirschsprung's associated enterocolitis is that we have fever because of organisms. We have abdominal distensions. We are going to have an explosive foul diarrhea because things are piled up for a long time. We're going to have lethargy. We're going to have dehydration, shock, and absent bowel movement. And then the complications from this, we can have toxic megacolon, we can have sepsis, we can have multiple organ dysfunction, and it is the leading cause of mortality when it comes to Hirschsprung's disease. Some of the differential diagnosis, we can have a meconium plug syndrome, where maybe we have a very thick meconium that had not come out, so have that failure to pass meconium, and have meconium ileus that is related to cystic fibrosis. We can have small left colon syndrome. We can have anorectal malformations like mucophorid anus. Hypothyroidism can cause severe constipation, intestinal atresia, as well as necrotizing enterocolitis, depending on the picture. So investigations, we can do a constant enema, and where we shall see a narrow distal segment and a dilated proximal transition zone, and then we shall have retain of contrast after 24 hours. So we are doing the pictures. We're going to take one imaging or one X-ray immediately after contrast, and then one 24 hours after. Then when we do manometry, where we measure the tone of the sphincter, we shall find that we have an absent rectal anoinhibitory reflex, and this one is a transient involuntary relaxation of the anal sphincter in response to rectal distension. So when you're doing this, and we have distension of the rectum, we expect that the anal sphincter is going to relax, but in these children, it does not happen. So then we can do the rectal suction biopsy, and this is the gold standard, and we shall see absent ganglion cells. We can see, that is when we stain, we can see hypertrophic nerves as well as increased acetylcholine. And remember, acetylcholine has an excitatory effect on the GIT. So we don't have an increased acetylcholinesterase within these cells, then sometimes we need to do a full thickness biopsy, but most of the time, actually before it was the gold standard, but they are kind of moving away from it because of the increased risk of things like perforation and bleeding. So when it comes to the management of this condition, you want to first of all stabilize the patient, and this is very, very important. You want to do neo, but also you want to do NG decompression. You want to give fluids and electrolytes to compensate for those losses, maybe through the diarrhea or through the vomiting. You want to do rectal irrigations and antibiotics if you have Hirschsprung disease associated enterocolitis. Then the definitive management, most of the time we do a pull-through where we remove the aganglionic bowel, or there's resection of that aganglionic bowel, and then there can be anastomosis. And sometimes it can be staged where we can first remove the aganglionic bowel, and then we do a stoma where the intestine is extruded to the exterior until maybe the child has stabilized more. So if you have an unstable child, or we have severe dilatation, or if we have the enterocolitis, you do not want to go and do an anastomosis within that environment. And then after the pull-through, after the stoma is stabilization of the child, we can do the pull-through and then the closure. So the major techniques used, we have a Swenson procedure where we have full thick resection to the dentate line. And the problem with this is that you have an increased risk to pelvic nerves because you are resecting the whole. It's a full thickness resection. Then we have the endorectal where we do a mucosectomy with a muscular cuff. And this is good because it preserves the pelvic nerves, and it's the most commonly used procedure to losses soil procedure. Then you have the duhamel procedure whereby there's a side-to-side anastomosis behind the aganglionic rectopod. So you leave the aganglionic part, but you connect the two parts that have the ganglion. So you connect them side to side on the side of each. Then you have the laparoscopic assisted transanal pull-through. This one has also been done, and it reduces the tremor and has better cosmetic outcomes. So post-op care is very important in these patients because we need to do anal dilatations, we need to case stool softeners, where you have to do perineal care, we want to monitor for the associated enterocolitis, and then you do the long-term follow-up. So some of the complications we have early, whereby you can have leaking open anastomosis, we can have abscess formation, you can have infection, and when you can have enterocolitis. Then late, we may have strictures developing, and this can cause obstructive symptoms that are on. We can have constipation, incontinence, recurrent enterocolitis, as well as perianal excoriation. So we have come to the end of this video where we have looked at the different manifestations of the Hirschsprung disease, what goes wrong, and how to manage. I hope you enjoyed it. See you next time. My name is Benjamin. Don't forget to subscribe, like, and share this video.